Get on, and we always want to give our thanks to Sanford Burnham Medical Research Institute, who offers this great facility to us free of charge. So that helps our financing, of course. And let's go through who makes this thing go. Lyle LaRoche, our president. Raise your hand so everybody can know you. Gene Van Vliet. Where's he? Oh, that's me. Okay, thank you. George Johnson, who couldn't make it. He's easily recognizable because he's 5'18". Bill Manning, who handles our video, and as most of you know, or newcomers should know, makes a DVD of every meeting that's generally available by the time of the next meeting. So especially with our good doctor today, you'll want to pick up that video, I'm sure. John Tassi, who runs our website, he sits in the back so he can, so nobody can notice him napping.
I'm sorry, I'm not the librarian anymore.
No, I didn't update this. Bill Bailey took over the library quite some time ago. Thank you for that. And Jim Kilduff is our greeter, the smiling face. All newcomers, did you get a package of information? I hope so. One more set? Okay. And then last but certainly not least is Chuck Grimm, who gets this thing all set up for us to go in the morning. All these people are volunteers, and I guess this is a good time to say we've had a plea out for quite some time to try to get people involved in taking over the responsibilities that George has been handling as well as mine, because we're getting up there and we need some new faces to come in and start helping this group continue the success it's had over all these years, started by this gentleman here. So give some thought about it, because we really, really need help. Okay, in the newcomer package, there's a cover sheet. It's not yellow anymore. Please make sure that it comes back to me. We started to mention the hand in the cover sheet that you have, all you newcomers. Bring them up to the podium after the meeting or during or whatever. And I call each one of you on Monday and go over your situation and see if I can personally help you and lead you different directions. So it also has information about the different articles and booklets. And as I mentioned, I'll be in touch with you the first of next week. Here's our purpose, and we share patient-focused experience on becoming your own case manager. And that's becoming more and more necessary because doctors are so busy these days that you don't always get the attention you need. So you need to fill yourself full of information like you could get here. And so if he gives you an answer or no answer at all, you can ask him questions to get answers. We are not professionals, but a group of experienced participants, and we'll find out how many that is pretty soon. And by any sharing by anyone in this meeting should not be a substitute for medical counsel. We cannot do that. Should not do that. We do need your support. Over here, some baskets. We need some help getting around the room here. We are a 501c3 nonprofit organization. Donations are tax exempt, so we prefer that you put in there things that end in zero. That helps us do what we do, and we do not have any medical or religious affiliations. We're quite unique in that. So. Okay, here's some of the ways we support you. I've already mentioned John Tassi, who can also handle computers, as you can see. He does our website. It's really a good website, has a lot of very effective information. Many of you saw the library, and it's got a lot of good books and current information. Any papers and newsletter. Where's our guys? Bill Lewis, he's standing right here collecting money, does the summary of each meeting in the newsletter, and Steve Pendergast, where do you end up? Back up here. He's the editor of the newsletter, and does a wonderful job, and you're always notified through the website when it's available for you. We also, there's George and I are capable of doing outreach to new members for any men's groups or something like that want somebody to talk about our disease. We can take care of that for you. And we have monthly meetings on the third Saturday of every month except next month. We don't meet in December. And in January we start all over again with our always welcome guest, Dr. A.J. Munt from UCSD, Chairman of Radiation Oncology. He came today just to make sure we're doing this right. Okay, we're going to do a little survey here to help the speaker as well, but it'll surprise a lot of you. How many are here for the first time? That's wonderful. That's wonderful. I hope you can learn from this. I know you'll learn from our speaker and talking with other guys around here. How many of you are just recently diagnosed? Okay, good. How many of you have had prostate cancer for up to 1 year? Okay, keep watching. How many have had it for up to 4 years? Okay. From 5 to 10 years. Looky there. Don't be frightened, folks. Being new people. 11 to 15 years. There you go. Higher. See there? You newcomers. Don't be afraid. Okay, let's go for the high number. Bob?
27 years.
Whoa.
27. I'm pushing 18 now, so I'm happy too. Okay, now we're going to talk about different kinds of treatments. How many of you are on active surveillance, meaning you've done no other treatment but active surveillance trying to find your way? Look at that. Okay. How many have had surgery? Interesting. How many have had radiation? See there? How many are on ADT or hormone therapy? I got to just pretend my hand's up on all these. I have not had chemotherapy. How many have had chemo? Okay. How many have had the new treatments like Provenge? Let's think of, huh? Zytiga, Xtandi, Lutetium, that's right, and I just got a new one called Lynparza, thanks to my good doctor. So a lot of new things keep coming to help us along. Know that. Okay. Of all of the ones here, how many of you are now experiencing recurrence? Unfortunately, that happens to too many of us. Okay. And how many are undecided on what to do next? A lot.
Can I ask you a question?
Yes.
Can I ask you a question? I read in one of the magazines that you have on the table there that one of the doctors from LA that does the iFlu said that people that have radiation usually comes back. People that have had radiation, usually the prostate cancer comes back. I was wondering if the people that have had radiation here, how many people have had recurrence?
I think statistics show that that's really not true.
That's not true.
Yeah.
Okay.
But that's not to say that that does come back on some people. Okay.
Thank you.
Okay, here's today's agenda, the great doctor. But before we get off with him, I have a gentleman who wants to make a statement to Dr. Lamb. This is Daryl Dixon, who's been through some.
I've been around a little bit.
Yeah, he's been through some good stuff.
I just want to say good morning, and I'm Daryl Dixon. I'm sharing this wonderful trip called life, and I want to thank Dr. Lamb for helping me and you through it. And I have a little gift for you.
One. Okay, good morning, everybody. About 20 years ago, I was diagnosed with prostate cancer, and I thought it'd be a great excuse to start a support group. I always wanted a support group. So here we are 20 years later, probably the most successful men's prostate cancer support group in the United States, and I thank you all for participating. I especially have to thank Gene Van Vliet. About 10 years ago now, we were meeting in a church up in Allied Gardens. We had room for about 50, 60 guys, I guess. Grim was there, Bob Keck was there. And so this gentleman walks up to me after the meeting and he said, "I'd like to help." So I handed him the microphone and I said, "I'll see you later."
Boy, is that true.
So over the years we have evolved. We went from the John Moores Cancer Center because of Dr. Munt, and then we wound up here at Sanford Burnham because we outgrew everything else. So in the process of doing all that, in my particular instance with prostate cancer, I discovered a doctor up in Marina del Rey, and he was new to being a doctor part. So I went up there and I met him, and we became friends. And so over the years, we have referred probably hundreds of patients up to Dr. Lamb. And then in the process of Dr. Lamb knowing me, Dr. Lamb met Dr. Munt. So A.J. Munt and Dr. Lamb now, when you counsel with me, I always tell you, go see these guys. Because you're going to get an honest opinion. They're not going to tell you to go do one thing, because that's what they know how to do. And so in today's world, Dr. Lamb and Dr. Munt, they're here. Richard comes for the last meeting, and AJ comes for the first. So I just want to give you a little history of these two guys. And as far as the medicine part goes, it speaks for itself. I mean, that gentleman just told you how many lives people call me, telling me, they're crying in the phone, telling me that these two guys. So, with that, I give the microphone to my dear friend Richard Lamb, and he's always welcome here, and we always like to take him out to dinner.
Boy.
And last night we had a hell of a time.
Thank you, Lyle.
I'm going to open up the gift first. Oh my gosh, this is heavy. I'm just going to take it out. So this is a very beautiful granite or marble snail. Beautiful. Thank you. Did you make this?
Slow and easy.
Okay. I'll talk slow today too. I'll take it. Thank you, Mr. Dixon. All right. Okay, so morning. Thank you for having me. Gene, Lyle, we had a great dinner last night. That was a good start. Now I'm a little groggy. But I'll try to be sharp and answer all your questions after the discussion. So today's discussion is about androgen deprivation therapy. It's a topic that doesn't apply to every patient in this room, but it is a pretty important topic for men with prostate cancer. So the basis of, people say, oh, we're looking for a targeted treatment to treat prostate cancer, and then we just find that target like a smart bomb, and then we get rid of the cancer. Well, we can't get rid of it, but we really have a very elegant and simple target in prostate cancer, and that's testosterone. Testosterone is a hormone that we all make. We make a lot of it during puberty, and it basically, for every man, it stimulates the kind of what makes a man. It stimulates reproductive tissue, muscles, libido, and it's a hormone that we make a lot of during puberty, and we still make it the rest of our lives, but over time, as we get older, we make a little bit less. Most testosterone is made in the testicles, as you guys should know, but some testosterone is also made in the adrenal glands, which sit above the kidneys towards our back. And it turns out that testosterone, we call testosterone a ligand or a food. It's the main food that stimulates prostate cancer, but it also stimulates the prostate. So not just the benign component of the prostate is also stimulated by testosterone. So as we grow older, our prostate grows because since puberty, testosterone has been feeding it. So kids don't have enlarged prostates. So how does testosterone promote prostate cancer? So basically, let's see here. Here we go. So this little, right here is the brain, and the brain basically makes a bunch of hormones starting at the hypothalamus to the pituitary, makes this hormone called luteinizing hormone. And once this luteinizing hormone reaches the testicles, it stimulates the testicles to create testosterone. And it also, there are some hormones from the brain that stimulate the adrenal glands that make testosterone. And once testosterone goes into a cancer cell or a benign cell, it gets converted by 5-alpha reductase to dihydrotestosterone. And dihydrotestosterone binds to the androgen receptor. And this little combo here then gets transported into the cancer cell's DNA. And when it sits on the DNA, it then promotes the DNA to replicate and then the cells to replicate. So intuitively, if you get rid of testosterone via androgen deprivation therapy, you can starve the cancer cells of the food. So this is how, one way to do it. But we're a little bit more elegant with, less traumatic, okay? So what is androgen deprivation therapy? Well, it's basically depriving the cancer cells of androgens, which is testosterone primarily. The androgen deprivation therapy leads to cancer death, cancer cell death, and as I said earlier, testosterone supplies the food for cancer growth. And this is the kind of the breakdown of production, testicles versus adrenals, 90 to 10. It is the primary treatment for prostate cancer that treats the whole body. So when we treat prostate cancer, we think about treating the cancer or treating the prostate, we think about removing it or radiating it or HIFU or cryosurgery. But this treatment doesn't, these types of treatments are called local therapy, which is a whole nother discussion. But local therapy treats the cancer in the prostate. So systemic therapy is androgen deprivation therapy, and that's the main type of treatment that treats cancer all over the body, including the cancer within the prostate. So this concept that removing testosterone leads to cancer cell death was discovered by Dr. Huggins, who eventually won a Nobel Prize for this. So there are multiple methods of androgen deprivation therapy. The old way, many years ago, before medications were discovered, was basically surgery. So removal of the testicles would remove over 90% of the testosterone. Now there's medications, such as Lupron and other agents we'll briefly go over. And then there's a different type of testosterone deprivation, and we'll go over that as well, called anti-androgen monotherapy. So again, before even thank you, George, for making it. So when I started, this is what we had to do for androgen deprivation therapy. So I think Daryl, maybe I'll use your snail and drop it. Yes. Okay. So we don't have to do this anymore. So nowadays, what we do is typically we use injections, medications that basically tell the testicles to go to sleep temporarily. And so, a lot of these compounds you may have heard of, they include Lupron, which come in, monthly or every 3 months, every 6 months. There's implants that last up to 12 months. There's medications called Zoladex, which are subcutaneous. So these are various brands of basically doing the same thing, okay? And these are called LHRH agonists. And they all take, once you get an injection, it takes a couple weeks for it to kick in. Another type of injection is called LHRH antagonists, and these are somewhat newer, about 10 years. They work, the only difference is, practical difference is they work a lot quicker. And you don't need to take any medicines prior to these injections. They work quicker. We use it if we want an immediate impact. So someone who's critically injured, the cancer might be very dangerous. For example, there's some cancer in the spine and causing weakness and paralysis, and you need to shrink the cancer right away. You could do something called LHRH antagonists. Some men who have very bad urinary symptoms because the cancer is just kind of blocking things and you want to help them fast, again, you could do something like this. The only downside of this injection is it's given once a month and it hurts a little bit more than the traditional injections. Another type of androgen deprivation, which people don't typically think of as an androgen deprivation therapy, is abiraterone. So abiraterone, there's another name for it, it's called Zytiga. And by its mechanism is different than simply telling the testicles to go to sleep. Abiraterone itself blocks this enzyme, which is very important in the production of testosterone. They call it CYP17. So this is a little bit of a complex slide, but there's a couple interesting points about the CYP17 enzyme. So you guys could see here that testosterone is one of the, first of all, the interesting thing is a lot of these hormones come from cholesterol, okay? So that's why there's some studies, research going on about lowering cholesterol as having an anti-cancer effect, the statins. But this is kind of like the mother precursor of all these hormones that can feed prostate cancer. So what abiraterone does is it blocks this enzyme, which is very important in the production of testosterone, dihydrotestosterone, aldosterone, cortisol. So by blocking this enzyme, you're cutting down testosterone production. Okay. But by its potent blocking, abiraterone causes low cortisol levels, low aldosterone levels, and then that has some impact on the side. It has a relationship to the side effects of this compound. Another class of drugs which have been around for about 30 years is called anti-androgens. I'm going to go over the older ones that were developed 20, 30 years ago, and these include bicalutamide, flutamide, and nilutamide. So anything that ends in a utamide is an anti-androgen. And what anti-androgens do is And this graph or this figure shows various mechanisms of the various pills. For example, abiraterone blocks the CYP17 enzyme, well, that's right here. 5-alpha reductase blocking is using medications like finasteride and dutasteride, and that blocks the production of dihydrotestosterone from testosterone. And it's dihydrotestosterone that binds to the androgen receptor that then goes into the cells. So what these older anti-androgens do is they basically disable the receptors. So it prevents the receptors from binding to the DNA. It prevents the receptors from binding well to the dihydrotestosterone. And these medicines have been around for many years, and they work fairly well. These are some of the newer anti-androgens that were developed and then subsequently approved in the last 2 to 10 years. And these include enzalutamide, or otherwise known as Xtandi, apalutamide, otherwise known as Erleada, and darolutamide, otherwise known as Nubeqa. Okay. So these newer anti-androgens, and I'll use the enzalutamide as the example, they not only block the interaction between the receptor and the cancer DNA, but it blocks multiple levels of testosterone and receptor interaction. So it blocks the testosterone from even reaching the receptor. It blocks the receptor testosterone complex from moving into the cancer cell, and then it blocks this receptor testosterone complex from attaching to the DNA. So it's kind of like a super Cassidex, I tell patients. A little bit of background before we dive into the androgen deprivation therapy. This is a fairly common or a common scenario for patients in their prostate cancer journey. So somebody finally gets diagnosed with either symptoms or rising PSA or abnormal prostate exam. And the first thing is we usually do treatment to the prostate. So that's called local therapy. Okay? And oftentimes local therapy works, so patients are cured and the cancer never comes back. But unfortunately, there are still a lot of men who relapse. And when they relapse, it's usually manifested by rising PSA. Okay? So when the PSA rises, the typical approach when the PSA rises is that's when we use androgen deprivation therapy. And androgen deprivation therapy works for a long time, and then eventually it stops working. So what happens is we get a condition called castrate-resistant prostate cancer. And then typically, when the cancer becomes resistant, eventually we see cancer in the bones or the lymph nodes or somewhere else, and eventually the patient can die from prostate cancer. So this process, as you guys can experience and see, can last anywhere between 5 and 20 years. Okay? And of course, during many of these times, either you can be cured or you can be controlled for a long time before things might get a little dangerous. So we don't do androgen deprivation therapy for everyone, even though it's very effective. We have lots of studies to guide us on when to use androgen deprivation therapy. The typical situations would be someone who's newly diagnosed, who needs treatment to the prostate, but they have higher or intermediate to higher risk cancer. And giving some androgen deprivation therapy in addition to the local therapy does help things. We also use it, as I indicated earlier, when a patient has relapsed cancer, and we'll talk about the studies supporting that. And we also use it when patients have metastatic disease, and we also still use androgen deprivation therapy when the patient has castrate-resistant disease. We do not use it for patients with low-risk cancer. Okay? We do not use it for patients who are getting surgery before or after surgery. So unless, so there are very rare instances if a patient is about to get surgery that they should even get androgen deprivation therapy. So what is intermediate risk prostate cancer? So these are some of the parameters that puts a patient in that category. Someone with Gleason 7 prostate cancer, meaning 3+4 or 4+3, they usually don't have a very large nodule or they don't have one at all. Their PSA is high, but not too high. So, greater than 10, less than 20. They have, more than 50% of the cores are involved with cancer. So that's another criteria. And usually when we look at the prostate, the cancer is not that large. It's not breaking through the capsule. It's not invading the seminal vesicles. It's not invading the rectum. Those patients would be considered high risk. So, medium, small size cancer that hasn't broken through. So in this situation, when you treat the prostate, by adding 4 to 6 months of androgen deprivation therapy, you actually improve the cure rate. And not only do you improve cure rate, and if you don't cure the patient, it delays the relapse. And also, if you take a group of intermediate risk men who took androgen deprivation and a group of intermediate men who didn't, just the 4 to 6 months will actually lead to a better survival. Okay? So 4 to 6 months of androgen deprivation therapy. But you got to take into account all these men will live regardless if you get androgen deprivation therapy. All these men will live, a long time, probably 15 years or more. Okay. So the take-home message for intermediate risk prostate cancer is it's unlikely a fatal disease. And if you want to get better results, you might consider 4 to 6 months of androgen deprivation therapy. So the next slide goes over the typical patients who have higher risk prostate cancer. So these are patients who have a higher Gleason score, meaning the Gleason scores of 8s, 9s, and 10s. Even when you examine a patient, the doctor feels a bigger tumor. That already puts you in a higher risk category. The PSA is usually greater than 20. More cores are involved with cancer. And usually if you do a prostate ultrasound or MRI, you're going to see more cancer breaking through the capsule, invading adjacent tissue. So we're dealing with a more aggressive, higher volume cancer. So intuitively, you will need a longer course of androgen deprivation therapy. For these types of men where the risk of cancer not only being in the prostate is there, but the risk is that there's a higher risk that there's cancer elsewhere. So no, that would be metastatic. So that would be a category that should get androgen deprivation as well. But this is high risk, no sign of metastatic disease. So what you're doing is you're thinking there's a good chance there's metastatic disease, and yet we can't radiate the whole body. So the only thing we can't cut the whole body. So all we have left is this targeted treatment called ADT. But you need quite a long treatment to improve outcomes. Cure rates, delay relapse, improve survival. Still, these men with high-risk disease, there's a very good chance they're going to live longer than 10 years. So these are non-metastatic, okay? This is treatment plus diagnosis. So you're treating around the same time as diagnosis. So it's pretty similar. This is a kind of a moving target. I would never say, oh, studies show you're going to live 10 years and that's that, and so start counting the clock. But there's always, because there's always new medicines, that goalpost keeps being pushed back. In some really high-risk patients, we actually even add abiraterone to androgen deprivation therapy and radiation therapy to improve the outcomes. And there's good data for that. So we'll talk about that in a minute. So another scenario where androgen deprivation therapy, or ADT, is indicated is when someone relapses after surgery. So typically, if you relapse after surgery, a lot of doctors will say, well, your PSA is rising after surgery. There's a good chance there's still cancer in that area. Let's radiate that area. But just to be safe, we'll add 6 to 24 months of radiation, androgen deprivation therapy. So let's talk a little bit about why one would, the concept of radiating the prostate area after surgery. Well, We think, that after surgery, if one's PSA goes up, there's still some cancer within that area. So we then send the patient to see a radiation doctor who basically isn't radiating at a cancer spot. They're just radiating at a region where they think the cancer is. Okay. So they radiate that area and hope that there's cancer in that area. It turns out that, yes, the success rate could be as low as 20%, but it could be as high as 70%. So just by radiating an area. And the 20% to 70% range is basically the likelihood that the cancer is only in that area. So if I tell someone, oh, there's a 20% chance you're going to be cured with this radiation to the area, that means there's a 20% chance that the cancer is only in that area. If I say, oh, your cure rate's 70, your failure rate, your success rate being 20% is low, of course. So in other words, there's a 80% chance when you radiate this area, there's cancer outside the area. So there's a low success rate. If we think the cure rate is 70%, that means we're really confident that the cancer is only in that area. Okay? So how do we determine this 20 to 70% range? Well, it depends on the patient's Gleason score. Depends if they had surgical margins that were positive, meaning if the surgeon said, oh, I do think there's some cancer left behind based on the surgery report, then there's actually a higher chance that the cure rate is higher. We also, the lower your PSA when you do radiation therapy, the higher your cure rate. So if you wait till your PSA hits 3.0, your cure rate's going to be probably 5 to 10%. So you want to do the treatment when a PSA is less than 1.0. Another factor is how low your PSA dropped after surgery. If your PSA went to 0 and it stayed there for a long time and then gradually went up, then there's a better chance your cure rate's going to be higher. If you do surgery and your PSA nadir or low point never got to 0.2 or 0.1, then there's a higher risk that you're going to fail. Okay? So the higher the likelihood I think you're going to relapse, the higher the likelihood one would recommend the androgen deprivation therapy. And there's studies supporting either using 6 months of androgen deprivation or 24 months of the anti-androgen monotherapy. Does that make sense? It's a complicated discussion here. So let's say you relapse despite surgery and despite radiation, or you relapse after radiation, or you just relapse after what we call local therapy. We know that androgen deprivation therapy can control, not cure, but control the cancer for a long time. This is data from about 10 years ago showing that it takes about 10 years before the ADT loses its effect. So in other words, it takes, we could control the cancer for about 10 years after one relapses from local therapy. How about for metastatic disease? So metastatic disease is not only do you relapse with the PSA rise, but you relapse and you see the cancer. So you could see it in the bones, you can see it in the liver, sometimes you can see it in the lymph nodes. So that's called metastatic disease. So for metastatic disease, ADT does work, but it doesn't work as well. It works anywhere between 2 and 5 years. Of course, there's exceptions of men working for 8 to 10 years as well. But the more cancer you have when you relapse metastatically, the shorter the duration ADT will work. Okay. So in that setting, if someone has metastatic disease, regardless of relapsing or suddenly presenting with metastatic disease, I just told you ADT only works for a fairly short number of years. So we want to improve it. So these are ways that we've found that will improve ADT success rates. So the first drug that improved ADT for metastatic disease was a drug called Taxotere, and that's chemotherapy. And that's based on a couple trials from 2015 and 2016. We went over this a few years ago in one of the lectures, and I think we went over this as well. Nowadays, we're using less chemotherapy to make ADT work better. We're using one of these stronger ADT medicines called abiraterone, based on 2 trials in 2016 and 17. Enzalutamide based on this year's publication of the Enzamet trial, and apalutamide based on the Titan trial. So this is new data showing that these 2 drugs added to ADT improves outcomes for metastatic disease. Okay. And we'll go into the nitty-gritty details in a minute. Okay. So this is the first trial I'm going to go over, and I think this slide was used a few years ago when it first came out. Basically, they took about 1,800 men with metastatic disease, and they gave them, and basically these men did not get surgery or radiation to the prostate because the cancer had already left. So they gave these men, half of the group got ADT, androgen deprivation. The other half got ADT plus abiraterone. And this was the overall outcome. So the biggest things to take home would be the survival rate at 3 years was higher. The likelihood of progression was only 25%. So at 3 years, there's a 75% chance the cancer is still under good control if you took the combination of ADT plus abiraterone. If you took ADT alone, at 3 years, there's about a 50% chance ADT stopped working, just like the data the generalization I told earlier. And these are the number of men who had treatment failure, 248 out of about 1,000, and 500 out of 1,000 for the group that got ADT by itself. From a practical standpoint, the group that got the combination had 50% less problems with their bones. So less bone pain or less bone fractures if you took the combination. So this is the Stampede trial that came out in 2017. The Latitude trial was very similar. They also took about 1,200 men. They combined ADT plus abiraterone versus ADT by itself, and you had very similar outcomes. So this group, their PSA was over 100. So ADT really only worked for a short period. But when you added ADT plus abiraterone, you had a much longer duration of cancer control. And this is another practical outcome that we look at. Endpoint is, when does one have pain? So you could, on average, it took about 1.25 years before patients started noticing pain from their metastatic disease if they took ADT by itself. If they took the combo, they hadn't even got to the average. When they looked at the data, the average time to pain was not reached yet. So it was about 3 to 4 years before patients did have some discomfort. This was more recent data using a different ADT-type hormone therapy drug called enzalutamide, or Xtandi. And again, this is basically telling you that using enzalutamide plus ADT, the difference about this study was they didn't use ADT by itself. They used ADT plus one of those older anti-androgens I talked about. So there's no placebo here. Both groups got drug. One got a newer anti-androgen, and one got an older anti-androgen. And you could see here the survival rates, there was a difference. There was a big difference between the time before PSA starts rising, 2/3 versus 1/3. Big difference between radiographic progression, more findings on scans. And again, this is more of a statistical number. 174 men progressed out of 560 versus 330 versus 560. So this drug will be approved as an alternative to abiraterone early next year as an add-on to androgen deprivation therapy. And so will this drug. This drug is called apalutamide, again, another utamide. And again, this is less mature data, meaning they've only followed these patients at the 2-year mark. And again, there was already a difference in survival and progression, and these are the two parameters, survival and progression. So this should get approved as well. So this is an alternative to abiraterone and enzalutamide for men with newly diagnosed metastatic disease who are started on ADT. Yes?
And so when you have up there ADT, you mean Lupron?
Lupron, Firmagon, testosterone, testicle removal, the hammer. so any type, okay.
Can we see a preview?
Yes. So this is the Enzamet trial. And then this is the Latitude trial. This is Stampede. So these are 4 trials basically telling very similar. I don't want to bog you down with the numbers, but they're all proven to make ADT work better. So 3 drugs other than chemotherapy. Okay. So yes, so let's say, despite someone who's on ADT and has stopped working, well, basically, the next treatment for castrate-resistant disease is more ADT. And so these are patients who never got enzalutamide or abiraterone or apalutamide. So these men never got these drugs in the beginning because the studies weren't out yet, but now their androgen deprivation therapy is wearing out. There's also a role of using these drugs. So in the metastatic disease setting, these 2 drugs are FDA approved for that situation. It turns out that in the last few years, there are men who are on ADT and it stops working, yet we don't see the cancer yet. And we don't want to see the cancer. So in that setting, all the utamides have been approved for use in that setting. So the goal of all these 3 drugs is basically to delay the presence or seeing or feeling metastasis in someone who's castrate-resistant who doesn't have metastatic disease. But eventually they will, so why not prevent them from getting metastatic disease? So these 3 drugs, they all delay. This was the first drug that got approved for this situation, and they delayed the appearance of metastatic disease by about 2 years. And subsequently, these 2 drugs did the same thing in the Prosper trial and the Ararens trial this year. They all delay the presence or visibility of metastatic disease by a couple years. I point this out, I want to point this drug out, darolutamide, because studies have shown that this utamide has less side effects than these utamides. So I think, personally, if I could use it as in place of all the other utamides, I would try to use this drug because it has less side effects. Okay. So primarily fatigue, yeah. But in very rare cases, seizures, and this drug has much less fatigue and no seizures. Okay. But they all and it appears to work about the same. Okay. So talking about side effects. So these are common side effects of men on ADT. And I wouldn't say, one gets all of these side effects, but, I would say anyone on ADT could have anywhere between 2 and 5 of these side effects. Hot flashes, let's go over all these side effects and talk about ways to maybe mitigate or prevent these side effects. Hot flashes, there's medications that will work. Maybe even acupuncture sometimes works. The onset of fatigue from androgen deprivation therapy typically kicks in after 2 to 4 months. If you do a lot of exercising, eat healthy, and weightlifting, you can either not have fatigue or you could delay the onset of fatigue until month 10, 12, 14. So weightlifting is very important. Some men get mild breast enlargement. And in those situations, once it starts growing, you can't shrink it. So you need to prevent it with some medications, or you could preemptively radiate the breasts. Okay. people on androgen deprivation therapy can lose bone density. Just like when a lady goes through menopause and loses estrogen, a man on ADT loses testosterone and can lose bone density. On average, we lose between 4 and 6% per year of ADT. So, which doesn't seem too much, but if you're on ADT for 2 years, 5 years, you could lose a lot of bone density. So calcium, vitamin D, some men need to take some medications to prevent bone loss. Muscle wasting goes hand in hand with the fatigue, and one could really preempt that by doing the weightlifting. Erectile dysfunction, and more so related to a lower libido, and as a result, impaired erections. So it's hard to make someone not, give someone libido when he doesn't have testosterone. So what we tend to do is we, at least even if we can't give you a good erection, we want to prevent your penis from shrinking. So we give people a low dose Cialis every day, and that will at least get the blood flowing to prevent penile shrinkage. And if you're amorous enough and would like to have sex, the Cialis or Viagra, that will help as well, of course. Some people could get kind of melancholy, more emotional. Rarely, you could be overtly, outright depressed. And that's where we might need to do medications. Weight gain and diabetes go hand in hand. If you gain weight you gain weight because when you're on ADT, your metabolism slows down. And if you do the same amount of calorie burning and you eat the same amount, but your metabolism is slower, you will gain weight. And that could lead to a higher resting blood sugar and maybe diabetes. It could lead to higher cholesterol levels, which may lead to higher risk of heart disease. So again, eating healthy, exercising is it's a big cornerstone to mitigating some of these side effects. People can get a little bit of anemia, so not to the point where you're needing a transfusion, but that contributes to the fatigue. And we tend not to need to do any treatment. It's just a temporary phenomenon while you're on ADT. There are mixed studies showing or indicating there may be a link between long-term, not 4 months, long-term ADT and memory impairment, and maybe even dementia. So, and it's really not conclusive whether or not ADT causes dementia. I do know that ADT for sure decreases your concentration, and things don't register as well. You're more tired, you're not sleeping well, you have hot flashes, you're just not as sharp, and you don't concentrate as well. And some people will get misdiagnosed as early dementia because they're just not as sharp. But yes, I think there is a link between ADT and decreased attention span and maybe long-term memory impairment. Okay. All right. So one way to, other than not doing ADT, is another way to mitigate some of those scary side effects is do intermittent ADT or intermittent hormone blockade. So less side effects. It's definitely less expensive. You tell a patient you're on ADT, but you don't have to do it forever. It's just 9 to 12 months, knock the cancer down, and then you take a treatment holiday. Initially, people thought, oh, doing this intermittent treatment may decrease hormone castrate resistance. That's no longer the case. So this is kind of a more of a pictorial way to explain what intermittent ADT means. It's basically when cancer grows, you go on ADT, hormone therapy, cancer shrinks. You stop treatment, cancer grows, go back on hormone therapy, cancer shrinks. So you're basically going on and off treatment. Side effects, no side effects, side effects, no side effects, side effects, no side effects. And this graph, a more realistic way of looking at it is, at worst case scenario, 1 year of side effects, but you usually get 2 to 4 years of treatment holiday. Go back on treatment for about a year, you get 2 to 4 years of no side effects. So intermittent treatment, and you're still going to end up getting that approximately 10-year benefit of cancer control. Okay? So I'm not going to say you're going to get longer cancer control by doing intermittent, but equal cancer control, which, you know, with much less side effects. So, you know, we kind of pioneered this concept maybe 20 years ago, and now intermittent androgen deprivation therapy is kind of standard now. Okay. So all your doctors, wherever they are, most of them would recommend intermittent treatment.
Is that true when you do the intermittents, even when you have ADT and one of the newer pills?
It depends. So if you're using, it depends. You're less apt to do a treatment holiday when you have metastatic disease. And when do you use those newer pills? Metastatic disease. So even now, there's some studies showing that if you have metastatic disease, you could even consider taking a treatment holiday. Okay. So this is a side effect that's really more so, less with ADT, but more with anti-androgen monotherapy. So this is with using Casodex by itself. Okay. On that note, I'm going to thank everyone for your attention, and we have some time to go over some questions and go from there. Thank you.
Well, thank you. Let's scan the audience, and the rule is we'll start here and sweep here, and then we'll come back, so you'll all get to answer the questions. And your role, you want to bring your chair over here. Here's a relaxed, comfortable person. And the only requirement you have is to repeat the question, or that part of the question you choose to answer. Okay? All right, let's start over here. First guy.
You might know, the outlier in my case, after Gleason 9, was the metastasizing to the lymph nodes. I have lymphedema all the way down on this leg. And I guess my question is, there doesn't seem to be a lot of experts in the lymphatic system. And all of the various treatments have a little disclaimer that says, may increase swelling in the lower extremity. And I certainly don't want more lymphedema. I don't know where this factors in, but it's a concern of mine. I have come down to 0 point something on each testosterone and PSA. And all the MRIs say that the prostate is normal and that the lymph nodes are normal. Where do you go from there?
So the question is, you've had some treatment and you have leg swelling. Okay.
Yeah, excuse me, bicalutamide and Lupron.
Okay.
1 year.
Have you had radiation or surgery?
No.
So you're diagnosed and they told you it went to the lymph nodes. Let's not do treatment to the prostate anymore, correct?
Actually, not told me I shouldn't have more treatment.
Okay. So, and then now you have lymphedema.
That's correct.
Okay. So the big question is how to manage lymphedema practically, right?
And not increase it.
Yep. So, you know, the most, you know, you're on the medicine that doesn't cause lymphedema, by the way, what you're on, okay? So if there is a day we need to, when the ADT stops working, we're going to have to add more ADT or add something different. And so the medicines that will have the least likelihood of giving you more lymphedema would be a different utamide. So enzalutamide, apalutamide, darolutamide. Okay. If you took abiraterone, which along with it comes with a little bit of prednisone, you could have a little bit more swelling in both legs.
Radiation?
So yes, there's a good chance you'll have more swelling from radiation.
That's where I'm at. Yeah.
But you know, in certain cases, if your lymph nodes and the cancer is really in a small area, and Dr. Munt, chime in if you feel like it, radiation treating if it's a small area, radiation to the mothership and the lymph nodes around will probably help you live longer, though.
Children, yeah.
So it's a balance.
Doctor, when cancer returns after radiation, is the current thinking more towards using ADT in a combination of different forms, like abiraterone with Lupron, or using it in sequence, using Lupron until it doesn't work, and then abiraterone, and then whatever, when each stops working?
Yeah. So this scenario is you've had radiation and the PSA is rising, so they say, oh, there's some cancer in the body, right?
Right.
So there's a couple scenarios. One is if we think the cancer is only in the prostate, one would consider doing something to the prostate again. Okay. If we think that the cancer is not just in the prostate or not in the prostate, but it's somewhere else, then you typically can't re-radiate the whole body. So then at some point you do ADT at the right time. And when you do ADT, then you have to decide, does the cancer warrant ADT plus one of the newer drugs, or the cancer is not so bad, just ADT first and do it intermittently, sequentially, until it stops working. So one scenario would be PSA is rising really quickly. There's some lymph nodes, then one might want to do ADT plus a newer drug. If your PSA is rising slowly, like 1 point a year, and your original Gleason score was 7, and we don't see where the cancer is, and you just want to keep things from growing quickly, then simple ADT used intermittently would be prudent.
Prior to surgery, I had a testosterone of 800, PSA 8.6, Gleason 9. Now, 10 weeks after surgery, my testosterone is still at 800. PSA is 0.01. Is there any indication that it would be necessary to use testosterone lowering treatment at this point?
So your case is just like that slide where one shouldn't use ADT at this point. Is someone who had surgery, you're in remission, there's no sign of relapse. I would not throw on some Lupron to be comfortable. It's not worth it. So, well, your testosterone was never, when they removed the prostate, they left your testicles alone. So your testosterone is just behaving the same before and after surgery. It's great. Enjoy it.
Question here, yes. Just as a person that's considering treatment, just diagnosed at 75, just diagnosed, I have a Gleason score of 7, so I'm in the risk area. What would you say I should be looking at? I've done an MRI recently, and nothing seems to be happening to the area that was diagnosed originally. So, what would you say I want to look at? What would you recommend that I don't want to do as a part of, call it active surveillance or whatever?
So as I alluded to earlier, intermediate risk patients still live another 15 years, at least. So I don't think whatever you do, I don't think you'll change your life expectancy. But whatever you do might impact upon how you live your life. So it's an individual decision in terms of what you want to do to impact the rest of your life, not how long you live, but what side effects you might get. So, if you do active surveillance, the side effect might be anxiety and frequent doctor's visits, okay? If you do some sort of treatment to the prostate, the side effects might be sexual issues or bowel issues, urinary issues. But you get closure, there's a very good chance you'll get closure if that's important to you. If you want closure and some insurance, then you do treat it to the prostate and maybe do the 4 months of ADT. But regardless of what you choose, Oh, another way of looking at it is if you do treatment to the prostate, there's a good chance you're cured and you could kind of move on with your life and just run the show here and volunteer. Or, or if you, you get treatment, you never have to worry about getting ADT, because some men who don't get treated or they relapse, one way to help you live 10, 20 years is intermittent ADT. So some people end up choosing treatment to the prostate so that they never have to face the possibility of doing ADT. So everyone has a different priority.
Okay.
Yes, sir. How do you find out about what trials are available to get into the programs, into the trial programs for these improvements that are out there? Where do we find those lists that we can apply for?
Yeah, looking for trials for patients trying to find trials, and even doctors trying to find trials, it's not easy. But clinicaltrials.gov is a very, the website with all the trials. And you just type in some keywords: prostate cancer, relapse, hormone therapy, chemo, stuff like that, immunotherapy. So otherwise, you do have to go to a doctor and have them do the legwork.
Thank you.
Okay, any more? All right.
Do you have recommendations for ways to lengthen ADT holidays, such as metformin or even radiating a dominant lesion if a PET scan shows a dominant lesion?
Yes, so I do think treating, let's say someone has metastatic disease, but there's only a couple here and there, and we know that these are the ones that are making the PSA go up when you're off treatment. Why not zap a couple and maybe prolong the time that you don't have to go back on ADT? And so I think for select men with low volume isolated areas, we call that oligometastatic disease, radiating will delay going back on ADT. In terms of medications, dutasteride, finasteride, they will prolong treatment holiday. So that's the one that lowers dihydrotestosterone. Metformin, we don't have enough convincing data to say that yet.
Yes, sir.
Yeah. So if you do radiation for low-risk disease, you don't need ADT. If you do radiation for high-risk disease, you need ADT, and then some. So it's really the splitting hairs is the intermediate group. So in the intermediate group, there are some men that should get ADT, the men who have 4+3 disease, or larger cancers, or more cores, or the men who don't need ADT are the men who have smaller cancers, only 3+4 Gleason 7 disease. I don't think they need ADT.
Okay, back there.
Yeah, I noticed that you local cryotherapy in your department. Does that change your presentation at all?
Well, question is focal cryotherapy. That's a whole nother topic. That's one. It's a method to treat the mothership, which is different than systemic testosterone treatment. But in the focal cryo, the goal of focal cryo is to do less treatment, less side effects. Typically, in that situation, we don't recommend ADT with focal cryo. But it's something that it's a treatment that I've used and consider. It's in the list.
Okay, in the back.
Okay, if you're an intermediate cancer person and you've got at least one of those items that you're looking for, probably whether it's a VRA or a protein score or PSA, is it
just foregone that you need the ADT, or you can kind of...
Well, it's a combination of all those things that kind of give us a feeling. Either it's black and white or it's kind of gray. And we also take into account the patient himself, his age. Think of ADT as insurance. So not everyone buys insurance. So it's really you get some extra level of reassurance that you're going to stay in remission by doing the ADT. But let's say your cure rate is 75%, and ADT will make it 85%. So in other words, you're only going to change 10% of the people who are going to relapse. So ADT only helps 1 out of 10 men who do it in that situation. Just like insurance only applies to very few men who needed it.
Okay. Anybody there? Yes, sir.
I am prevalent on catheter intermittent, along with co-scar and I take metformin. What or dutasteride, what are the ideal points at which you go on and off PSA 1?
So, the general sense is the higher the PSA, when the PSA gets a certain point, you go on your treatment, you knock it back down. First of all, well, I'll answer the easy question first. We want to knock down your PSA to 0.1 or less. So that's the goal. And once we take the treatment holiday, at what point do we choose to put the patient back on? It's what point do I think the cancer is going to get dangerous? Or cancer grows like this, and then at an inflection point, cancer grows like this. So we want to knock the cancer down, not right here, that'd be kind of too late, not right here, be too early, kind of around here. So that's, approximately a PSA of 4 to 8.
You prefer dutasteride
or I think they're both equally good.
Thank you. Sure.
Question there, yes, sir.
Yeah, switching between Zytiga and Xtandi, I have the impression that if you've been on one and it stops working, that the other one's really not going to help. What's your impression?
So if you do, so the question is when one is castrate resistant or when one is already on a super ADT like Xtandi and then Xtandi stops working, then going on Zytiga, the likelihood of working is very low. And vice versa applies. It turns out that if you did Xtandi for CRPC and it stopped working, Zytiga only works in about 1 out of 15 men. Okay. If you add Zytiga and lower the Xtandi, it seems like you get maybe 1 out of 8 men get a response. Okay. So don't remove Xtandi completely. If you flip it around and you did Zytiga first and then it stopped working and then you use Xtandi, about 1 out of 4 men respond. So that's why I tend to do abiraterone first and then Xtandi later.
Yes, sir.
Oh, and then one more thing. There's a test called ARV7, which is developed by one of the companies in San Diego, actually. That actually might predict whether or not you should even do one of the next hormone therapy. So, yeah, that will kind of, if you have ARV7 mutation, then none of the next hormone therapy will work, like 1 out of 20. So I would only switch to another one of those if the ARV7 test came back favorable.
Then it's time for chemo.
Yeah.
Just want to know if I'm a candidate for intermittent ADT. I had a bad diagnosis, but everything's been working. After Casedex 7 years ago, and then followed by Provenge, my PSA has been undetectable. But I started at 408. So do I mess with what's working, or can I go to intermittent ADT?
Got it. So Casedex plus something?
Well, I had Provenge after I got down to 0.
And not on Lupron?
Deprivation. I still do deprivation
Okay.
every month and take Casodex every day.
Gotcha, gotcha. So, and how much cancer did you have when you were diagnosed?
I had 6 tumors up and down my spine.
Mm-hmm. And
That was April of 2011.
okay, and now, when's the last time you looked, measured the cancer or looked for any cancer?
About 6 months ago.
And everything's clear?
Everything's clear, yes.
And you got Provenge because of castrate resistance, or you just got it somehow got approved?
I got it approved thanks to Dr. Turner. I got it approved. I got it, went from 408 down to 1, and spikes back to 11. Casodex got down to 0.
Oh, okay.
But Dr. Turner said, well, you're still eligible for Provenge.
Got it.
So that just...
Got it.
The question is?
So the question is basically someone who has, who presented with a high PSA and a lot of cancer, and maybe even a transient castrate-resistant disease. And but now, after Casodex and Provenge, the PSA is basically undetectable. Okay.
Yes.
So the short answer is I probably would stay on treatment. Yeah. So another way of looking at it is, how long do I think you're going to get to stay off treatment? And when the cancer comes back, is it going to come back angrily? Okay. So I think your cancer you'll be able to stay off treatment at least a year, maybe 2. But when it does come back, it might be pretty angry. Okay. And the other third factor is, how motivated are you to stop treatment? So so I would say stay on it.
Okay, thank you.
Yeah.
Okay, yes, sir.
Yes, I took the triple hormone block 20 years ago and got 16 years of peace, and then it started to go up, and so I went on to Lupron again eventually, and then went on to Casodex again, and it's still climbing up, not under 10, but keeping it there. And my oncologist got me a grant for Zytiga, so I'm taking that now. But the problem is, I think I had it down, and now it's going up again with that. Now, I'm taking Lupron still. Should I also be taking Casodex, like I did in the original
No.
hormone block?
No. So basically, the cancer's back, and Lupron stopped working, so Zytiga was added, and Zytiga is beginning to stop working, correct?
Correct.
Okay. So this is the time where, applies to the other gentleman, you could consider, don't do Casodex, I don't think that'll work, but consider the super Casodex, which is Xtandi. Xtandi, Xtandi. Yeah. And prior to doing that, maybe ask your doctor to check the ARV7. And then the third factor is, yeah, but you could stop the Zytiga. And then you might want to get restaged, do some scans and see if there's any visible cancer. Restage meaning do a CAT scan, do a bone scan, see if there's cancer in the bones or lymph nodes. Okay.
That's why they got me.
Okay, got it.
The gentleman behind you.
So don't let it go too high before you switch.
Dr. Lamb, so nice to see you again. You haven't talked about lutetium. Now, you've had a little opportunity to work with lutetium. We had great expectations for it. I have heard that the lutetium, the kind of staying power of lutetium, is not that great. What's your experience?
So lutetium is, it's a medicine that we use when patients have what we call CRPC, meaning castrate-resistant prostate cancer, meaning Lupron has stopped working, or castration has stopped working. It depends on if you've tried abiraterone, Xtandi. if you tried 10 things and lutetium is your 11th treatment, I think the lutetium works about 50% of the time. And if it works between 4 and 10 months. And lutetium is, think of it as it's liquid radiation. So it's radiation in a liquid, and it's injected into the veins, and it goes where the cancer is and releases radiation at the cancer site. So the more drugs you've tried before lutetium, the less likely and shorter duration will work. I am optimistic that if lutetium was used right at the onset of castrate-resistant disease before trying multiple drugs, I think lutetium could work, I'm guessing 18 to 36 months without Xtandi, without Zytiga, without those drugs. So unfortunately, right now it's being studied in the very end-stage patients.
Okay, Joe in the back there.
I'm on Zytiga, and how long would you give Zytiga to know if it's going to do anything?
I would say a good 3 months.
Questions?
The question is how long does one stay on Zytiga to make a decision if it's working or not? So it could work really quick. So, a month.
Well, my doctor said give it at least 2 months.
Yeah, but I've seen cases where PSA doesn't go up, but it just kind of hovers. But by month 3, it starts dropping.
Okay.
Okay, question here.
I'm on I'm castration resistant. No, castration sensitive metastatic prostate cancer. Okay? On Zytiga. How long should I stay in Zytiga?
Do you have metastatic disease? Do you have Yes. So bone? Okay, so this is a gentleman with metastatic disease, and he was started on castration and Zytiga. And things are going well. Okay. Well,
How long should I stay?
so
And what's the next step?
yes. So the standard kind of correct test question would be you stay on it forever. Okay. If you have very little metastatic disease to begin with, and now there's absolutely no active disease, I would consider taking a treatment holiday.
Oh, thank you.
Right here. This man.
I want to go back to finasteride. That treats cancer, they say, low-grade cancer, and then also BPH. Right. And but for the cancer, no matter what, either one, it can give you like a high-grade, unusually high-grade cancer. Is that still true, or that's already passed on?
So the question is, in someone who's on finasteride, are you at risk of developing higher risk prostate cancer? The answer is no. That's been further studied. There's a higher likelihood you'll find the higher risk cancer, but not create higher risk cancer. Almost, yeah.
Okay, I want to apologize for not being here on time this morning. Has nothing to do with prostate cancer. It has to do with C. diff. You know what C. diff is? No. See, this month is the National CDC C. diff month. Awareness Month. I was made aware this morning that my C. diff has come back. It's a severe superbug. You get it in a hospital. You get it because you've been taking the super antibiotics. And it kills more people than prostate cancer. And so I've been on different kinds of treatment. And I'm between doctors here, between lung doctors because I had pneumonia that took me off Erleada, and then gastroenterologists because of my C. diff. And they didn't want me to take Erleada because of diarrhea. And then, of course, my prostate cancer doctors who want me to take my Erleada because it works for me. In fact, since I've been off of it, it's been tripling. My PSA has been tripling every month. So we're going to go on the new stuff. By the way, he's up to date. The new stuff is just been approved in July. So you're up to date. So I'm looking forward to that. The thing about the super bugs, the New York Times had an article Thursday. It's a silent epidemic. Hospitals don't talk about it because they're partly to blame for it. So it's something you want to avoid as much as you can, the super antibiotics, unless you really need it. And so that's what I have. And I'll probably switch over to something that has, I don't know if you've heard about it, it's a measure of likes or dislikes. It's called the Yuck Index. How high does it score on the Yuck Index? This new treatment now is doing fecal transplant. You take fecal matter from a friend and you put it in your system. And anybody want to volunteer as a friend? I'll take anything. No, I may have to do that. That is supposed to be very effective, so we'll see. But thank you for your forthcoming prescription when I see you next month, okay? Good. Because Erleada that I'm on, and the new one, which has fewer side effects, is very effective, but also it has some side effects that really get to me. And so that's why I do intermittent. By the way, a few doctors down here talk about intermittent. So that's a question you want to ask. If the Lupron and some of this other stuff bothers you, ask your doctor about it. We have the leading candidate or proof right here. Bob, you've been on intermittent for how many years? 25. See, it works for you. Yes, okay. All right. Gene, did you want to? Okay. Okay, let's go back to our scan here. Anybody? Yes, sir.
Doctor.
George, over there. Close up.
You got time?
Let's do 5 more minutes.
All right. Yes, you already had too much. All right, anybody have a question? All right, you.
Hi, Richard.
Hi, Phil.
Recently, I had radiation at UCLA. I did a high dose rate seeds where they put the radiation in you, and actually, in my case, 17 channels, and pulled it out, so they didn't leave the seeds in. And they did that over a 2-day period. And hopefully they got all the cancer. I was at Gleason score 8 by the National Institute of Health, and then I sent my slides to this top guy at Johns Hopkins, Epstein. He lowered it to a 7, but I've been going to see Richard for 10 years, and we decided to do, there was a time for me to do some treatment other than active surveillance. And now, my treatment was done in September, but my PSA has bumped, we went to see Richard just a few weeks ago, my PSA bumped up to 2. Richard told me that with some patients it bumps up. Now, how often does that happen, and when do you say, well, it's not working, it's not using it different?
So the question is basically PSA behavior after any type of radiation. So the first 2 months after any type of radiation, the PSA could go up. Almost everyone, their PSA will go up. So we really don't put much weight into the PSA the first 2 months after radiation. After surgery, the PSA is educational starting about a month afterwards. And then, so that's kind of the initial post-radiation bump. There's a different bump that happens 18 to 24 months later. That's when the PSA out of the blue bumps up to 3, 4, or 5, and then it drops back down in a couple months. That happens about 1 out of 4 men. Not a bad sign. It just happens.
Question.
I have a theoretical question. How come physical castration has been discarded in the discussions? In the sense of surgical castration, wouldn't that obviate many of these other problems?
Well, physical castration causes the same side effects as chemical castration, but it is more convenient. You don't have to get shots every 3 months, and it is permanent. So you can't do intermittent treatment when you do physical castration. One way of doing intermittent treatment, once you do physical castration, is you give testosterone when you want to take a treatment holiday, rather than stop treatment to take a treatment holiday.
Aren't the side effects worse?
From physical castration? No.
With a relapse after surgery, radiation, Calcidex, and then I went on Zytiga and Lupron, and after six months I'm on a drug holiday, and my PSA is like 0, and has been that way for 4 or 5 months. And is that a positive sign, or is that normal? Or?
Yeah, I mean that's very good. I would probably check your PSA every couple of months, and also check your testosterone level. So if your testosterone level hasn't recovered, even though you stopped taking meds and getting shots, your testicles haven't woken up yet. So it's almost as if you're still on treatment. So that's great. So that means despite having the ligand, the food, the cancer hasn't come back. That's great.
Okay, let's thank Dr. Lamb for the up-to-date presentation. Thank you very much.